name is Andreas Jerome, and I'm the Consulting Chief Medical Officer to Quanterix. It's a pleasure that you are able to join us today, and we'll have two distinguished speakers today presenting in particular on neurofilament assays and their clinical application. One is Henrik Zetterberg from Gothenburg University, and Henrik will go first. And then we'll have followed by Jens Kuhle from the University of Basel. Each have 20 minutes for presentation, and then we'll have 20 minutes for questions. And as you may know, if you've done this in the past, you are able to chat questions into the chat box, and I'll moderate those questions at the end of the presentation and give some other strategic remarks. So with this, Henrik, if you don't mind, we share your desktop. We'll jump right into it.
Yes, thank you, Andreas. The title of my presentation is Neurofilament Light as a blood biomarker for CNS disorders. And I would like to start with a background slide where we see where neurofilament light is expressed in the neuron. And the expression levels of neurofilament light is particularly high in large caliber myelinated axons. And this has made neurofilament light traditionally regarded as a biomarker for subcortical and white matter disease of the brain. The presentation I will give now will be on data generated with antibodies made by the company Human Diagnostics, and they are all specific to the mid-domain of the neurofilament light molecule. Here are just some old data on multiple sclerosis, a typical white matter disease of the brain, where we can see that CSF neurofilament light concentrations are the highest in the active phase of multiple sclerosis. And if you are far from a relapse, the biomarkers, the neurofilament light concentration in cerebrospinal fluid go down. This is another slide showing an association of CSF neurofilament light concentrations with relapse in multiple sclerosis. And if you treat patients with multiple sclerosis, CSF neurofilament light concentrations normalize. This is an image we would like to see in neurodegenerative diseases, but we haven't seen it yet. Most likely because the drugs do not work, or the neurodegenerative diseases are more complicated than multiple sclerosis, which is of course also a very complicated disease. But here the biomarker normalizes in response to successful treatment. Another slide showing basically the same result. If you successfully treat multiple sclerosis, your biomarker will normalize. Your biomarker of axonal degeneration or injury will normalize. Now, we have studied also acute traumatic brain injury to look at the dynamics of neurofilament light concentrations in lumbar CSF. And one group of people we have studied is people who voluntarily expose themselves to brain injury or concussion, and that is amateur boxers. So this is an old study where we examined 14 amateur boxers and 10 healthy age-matched controls. We performed CSF sampling after a bout and after a rest period of 3 months where the boxers were allowed to perform exercise but not spar or box. The time point, 7 to 10 days following the boxing bout, was chosen on the basis of longitudinal studies after stroke. So the lumbar CSF concentrations of neurofilament light reach a maximum 7 to 10 days after a stroke, and that's why we performed the CSF sampling at that time point in this cohort. And here we see a simple slide on the results, where you can see that if you look to the right here where you see the individual values, you see that the boxers who received many hits to the head or received a punch to the head which made them groggy, they have the highest CSF neurofilament light concentrations. Those who received few hits, they were not that elevated, but actually they were not normal using this variant of the assay if you compare to controls. We repeated the study in a larger cohort of amateur boxers, and the results were essentially the same with increased concentrations after bout. Here is a knocked out boxer. This boxer was knocked out when trying to qualify for the London Olympics. So he didn't make it to the London Olympics, but he had to rest after this qualification game. And he actually decided to not box again until his biomarkers were normal. So he came 10 days after the knockout punch. Then he came back 2 months later, and the CSF neurofilament light concentrations remained clearly elevated. And in total, it took him 8 months to normalize, which is in the green part of this panel. Those are the normal CSF concentrations. This indicates that there is ongoing release of neurofilament light into the brain interstitial fluid and the cerebrospinal fluid after a knockout punch for almost 8 months. Traditionally, neurofilament light has not been regarded as an Alzheimer's disease biomarker, but again, as I said in the beginning, perhaps more a marker of subcortical axonal degeneration or spinal cord injuries and things like that. But when we examined the ADNI cohort for CSF neurofilament light concentrations, we could see a clear elevation of the concentrations in Alzheimer's disease. And when grouping the individuals according to high, low to medium, medium to high, or low concentrations of neurofilament light, we can see that those with the highest concentrations are those that progress the fastest in their cognitive deterioration over time, as approximated here by the Mini-Mental State Examination score. So higher CSF neurofilament light levels predict a more pronounced decrease in MMSE scores. And we also saw longitudinal association with longitudinal change in MRI data on brain atrophy. But if you look across neurodegenerative diseases, this is a study by Tobias Gilbeck in our group, we can see that the Alzheimer's disease concentrations are not that impressive if you compare to other neurodegenerative diseases. So in this cross-dementia disease examination, we saw that frontotemporal dementias and vascular dementia are the diseases with the highest CSF neurofilament light concentrations. AD is statistically higher, but not as pronounced as for VAD or frontotemporal dementia. Across Parkinsonian disorders, we can also see the Parkinson disease patients with pure Parkinson disease, they have normal CSF neurofilament light concentrations, but atypical Parkinsonian disorders are clearly increased. And this can actually be used diagnostically. If you'd like, if you're in a movement disorder clinic, you could actually differentiate PD patients from atypical Parkinsonian disorders rather well using neurofilament light as the biomarker, which can be clinically relevant, I think, at least in some situations. This has been replicated in other studies as well. Now, we have been interested in trying to develop peripheral blood biomarkers for CNS disorders, and neurofilament light has been our top candidate. And what we decided to do was to transfer the human diagnostics ELISA onto the single molecule array platform. And Simoa is a technique where it's based on the basic sandwich assay, but the capturing antibodies is conjugated to magnetic beads. So you have beads with antibody, and then you have your sample with the molecule of interest, and then the detection antibody forming a sandwich. And this detection antibody is labeled with beta-galactosidase in this Simoa setup. The trick in this assay is that you pull, instead of having the detection reaction going on in a solution, you pull down the magnetic beads into microwells, where one bead will fit into one microwell that holds only 50 femtoliter volume. And then after you have added the substrate of beta-galactosidase, you seal the microwells with an oil film, and you allow the detection reaction to go on. And then you look at shining versus light emitting versus black microwells. And if you have diluted your sample so that most wells are negative or black, you can actually count molecules. So this is sort of a single molecule counting reaction, which makes the assay much more sensitive than the regular ELISA. And by transferring the human diagnostics ELISA onto the Simoa platform using a homebrew kit provided by Quanterix, we could rather easily gain in analytical sensitivity. And by doing this, we could actually see CSF neurofilament light concentrations that or serum or plasma neurofilament light concentrations in all plasma samples we examined, also from healthy individuals. So this allowed us to start examining serum or plasma neurofilament light concentrations across different CNS disorders. And I will show you some data on this. Here are some precision data. This assay has a reasonable analytical variation. We could also define a lower limit of quantification of 0.62 picogram per milliliter. We dilute the sample, we get a reasonable parallelism. sample stability. If you freeze those samples, not much happens actually. Here we did a direct method comparison together with Jens Kuhle, who will also speak later in this session. So we compared, this is ELISA with the human diagnostics antibodies, the human diagnostics ELISA, and then we had the same antibodies transferred, the same assays sort of transferred onto the mesoscale discovery platform, and then to the right you see the Simoa results. And in the A panel, you see that ELISA on the x-axis has you see clearly that low concentrations in serum will not be measurable with ELISA. It's a bit better with mesoscale discovery assay variant, but with Simoa we get measurable concentrations in all samples. And we see nice correlation between CSF and serum concentrations. And the different methods correlate in CSF, but not for obvious reasons, not in serum. This is the first pilot study where we examined severe traumatic brain injury patients. And on the x-axis, you see the different sampling time points. So acute samples, and then 1 day, 2 day, 3 day, and so on sampling time points. And you see that serum neurofilament light concentrations steadily increase over time. And we can also see that it's not in this panel, but those with the highest serum concentrations were the ones with the worst outcome. Those who survived until 1 year follow-up time point were a bit more normal, of course, but not entirely normal if you compare to normal control individuals in green to the right. We see this nice correlation between CSF neurofilament light concentrations and plasma neurofilament light concentrations. And this is, to my knowledge, the first correlation like this for an established CSF biomarkers to be seen also in a blood sample, which was delightful to see. And now we actually have data on 4 or 5 independent materials on this. This is plasma neurofilament light concentrations in HIV-associated neurocognitive dysfunction. In the C panel, you see CSF neurofilament light concentrations, and it's been well known for quite a while that individuals who have HIV-associated neurocognitive dysfunction or even HIV-associated dementia, they are the ones with the highest neurofilament light concentrations. And this is replicated in plasma in the B panel. We have also examined serum neurofilament light concentrations in frontotemporal dementia subtypes. As you remember, the CSF, when looking across dementia disorders, frontotemporal dementia is really the disease that stands out in regards to CSF neurofilament light concentrations. And this is replicated also in serum. So you see clear elevations in most frontotemporal dementia disorders. In one of the worst neurodegenerative conditions one could imagine, Creutzfeldt-Jakob disease, we see also very clear elevations. So to the upper left, you see serum neurofilament light concentration in sporadic and genetic Creutzfeldt-Jakob disease with very strong elevations of neurofilament light in Creutzfeldt-Jakob disease as compared to controls, and also dementia controls in this case. The similar changes are seen in CSF, which has been known for a while. You will hear much more about multiple sclerosis from Jens Kuhle, but this is also just one study we just conducted on treatment of multiple sclerosis with a disease-modifying treatment. And we see that most patients normalize over 12 to 24 months in regards to the serum neurofilament light concentrations in response to treatment. Here's a study we did together with Umeå researchers up in northern Sweden, where they performed an experimental study where they injected an intraventricular catheter to administer a potential medication against multiple sclerosis, progressive multiple sclerosis. You can see that this insertion of the catheter results in a sharp increase in neurofilament light concentration. So this is also indicates that this is a sensitive marker for, in this case, mechanical axonal injury. And here we have results from the amateur boxers. This is the same cohort on the same boxing cohort that I showed data on in the beginning of this presentation, CSF data. And here you see that the CSF data are replicated very well in plasma neurofilament light. So those who took many hits to the head have clearly increased concentrations in the A panel here as compared to those with few hits to the head. And both groups are increased as compared to age and gender-matched controls. In the B panel, you see the resting samples after the summer rest. And actually the boxers are not entirely normal, even though they haven't boxed for 3 months, which is probably, well, it is, to some extent it indicates that it's probably not that healthy for the brain to be a boxer. So Simoa allows for the reliable measurement of neurofilament light in blood. Plasma neurofilament light concentration correlates with CSF neurofilament light and is increased in acute TBI, as well as in several neurodegenerative and neuroinflammatory conditions. This study was done together with Human Diagnostics, of course, and here's a picture of the people in the lab in Gothenburg, Mölndal. Thank you very much.
Well, thank you, Henrik.
Yes, hello everybody. Thank you for the invitation. I would mainly like to present two studies in this webinar. One of the studies is the one that Henrik already alluded a bit on. This was, I think, a really interesting study to show directly the comparison between three relatively known, or some of them relatively known assays. One was the ELISA assay by Human Diagnostics, and on the other hand, the ECL, so the MSD assay for this, using the same antibodies as the ELISA, and then Simoa platform that we were collaborating with Henrik on, and these samples were measured in Gothenburg on the Simoa platform for serum NF-L. And I mean, this is where our group was mainly coming from. So we had established an assay for NF-L in serum and plasma samples using these two monoclonal antibodies. And this was published in 2013, where we already saw this, also mentioned by Henrik, these very nice correlations between CSF and serum NF-L measurements. And looking at serum NF-L, we saw clearly increased levels in different neurodegenerative, also inflammatory neuropathies, less clear in Alzheimer's. But very interesting and important finding was to see these correlations here, and also parallelism between serum and calibrators. And so this assay we used extensively to publish in different fields. When we looked in MS in 2016, we did see that the sensitivity of the MSD assay was not completely sufficient to quantify NF-L in plasma or serum samples of multiple sclerosis. So this was also an important starting point to switch towards the Simoa technology. And for this study, to directly compare these different methods, we selected pairs of CSF and serum samples based on what we had measured before. So we chose high serum and CSF samples, medium and low samples, and also some unmeasured pairs of MS. And when we looked at sensitivities of these different platforms for this assay based on acceptance criteria for calibrators, we already saw, and what was already known by Henrik's group actually, that the Simoa assay is indeed significantly more sensitive than ELISA or ECL. And interestingly also we saw several very high NF-L concentrations in the ELISA when measuring serum samples, and these were also in the supposed to be low samples or medium samples, and these, for example, 5 samples were below sensitivity when measured by ECL, or with Simoa pointing to the problem of potentially heterophilic antibody leading to maybe not correct measurements. And as Henrik already showed, so we compared CSF and serum levels with ELISA, ECL assay, and the Simoa methodology. And I think it's clearly visible that for Simoa there's a relatively nice correlation between, a very nice correlation between CSF and serum. And we do have these sensitivity issues with the ELISA, but also the ECL assay, leading to the inability to quantify significant numbers of samples. Looking at CSF, it's always nice to reproduce also what everyone would expect, but we've had these stories in the biomarker field before, especially in MS, that it's not easy to reproduce also things that one would expect, and this is very nice to see that if we use CSF and if we use the different platforms, we see a very tight correlation between the different assays in CSF. And looking at correlations in serum measurements between ELISA, MSD, we do see some sort of an association, but we have the sensitivity issues. Looking at Simoa, we see that all samples we were able to quantify all samples, which was not the case for the ECL assay, leading to the best correlation between these different platforms. So with this experiment, we saw that the Simoa platform was 126 and 25-fold more sensitive than ELISA or ECL assay, respectively. As I mentioned, we were able to measure all serum samples. We saw matrix effects for the ELISA and very nice correlations for CSF and good correlations also, especially between ECL and Simoa Technology. And we confirm that serum NF-L can be reproducibly measured in different platforms. And I would like to thank especially our collaborators in Gothenburg, Henrik Zetterberg, who has been a great help in also helping us to build up this assay in Basel, and all others in Basel, and also the sponsors. So thank you very much.
Well, thank you, Jens. Why don't we now continue with some of the questions which came into the chat room. And before we do so, again, I want to thank Henrik and Jens for presenting very exciting new data here. One of the things I wanted to point out, as this has come up as a question, these assays were originally developed as what we call the Homebrew program through Quanterix. These assays will now be made available as commercial kits at the end of November 2016, early December. Quanterix also has what we call accelerator lab services to be able to analyze samples, clinical, preclinical samples for not just neurofilament light chain, but also other biomarkers as part of the assay menu or through in-house developed assays as well. So we can come back to this and address this in more detail. So then a couple of questions which I think have come up here with regard to the relative concentrations of NF-L in plasma versus serum. Is this influenced by platelets? So in your analytical experience, Henrik and Jens, are the values first of all, have you done any analysis and matched plasma and serum samples? And if so, do we know if one matrix is preferred over the others, and we can qualify what preferred means? I don't know what first.
I could start to mention that we have done a formal comparison. It's a bit limited still, so as always, I think more research is needed. So please, when you collect samples, collect both serum and plasma. So for neurofilament light, it looks like serum and plasma levels are comparable, but that serum levels are a bit higher. We do not know why, but it's really on the limit of it's not a big difference. So I would almost say that they are comparable, but statistically slightly higher. Perhaps 1.2 times higher or something like that. But more research is needed. In the same experiment, we actually compared tau between plasma and serum, and there we have a more clear result, that plasma concentrations of tau are higher than serum. Again, we do not know the reason, and more research is needed. In regards to the question on release of neurofilament light from blood platelets, I think that is not a big issue for neurofilament light, because as far as I am aware, there is not much expression of neurofilament light in blood platelets, but I am not 100% certain on that.
Okay. Jens, would you comment on that?
I fully agree. I mean, we made the same observation that plasma levels are approximately 10-20% lower than serum levels, but they are extremely highly correlated, serum and plasma, but plasma levels are slightly lower in our experience, which is actually based on 50 to 100 paired samples. And for regarding platelets, I agree with what Henrik thinks about the release from platelets.
Okay. And then I guess a related question to this from a technical perspective, I think it was on your dilutional linearity slide, in order to see dilutional linearity now, what is the dilution of either plasma or serum sample for the Simoa assay?
Yeah, we use a fourfold dilution, just as the dilution that most often gives values within the range of the assay. What do you do?
We use for CSF we use 1 in 10, and for plasma and serum we use 1 in 4.
Okay.
But one can dilute more, and especially if you have samples with higher concentrations. And those of you who work with rodent samples, you might want to dilute more to save sample volumes. So neurofilament light is 100% conserved in rodents, and there you can actually dilute your sample more because the concentrations are a bit higher also.
It wasn't necessarily a question, but while we're on the topic of cerebral spinal fluid now, because of this being an ultra-sensitive assay, the most sensitive NF-L assay, soon to be commercially available as a commercial kit, what is the dilution in CSF in preclinical or animal samples and clinical samples?
I mean, for mice we used, for CSF we used 1 in 14.
Okay.
And for plasma we used 1 in 4.
In human CSF, is this the same dilution?
Human CSF we use 1 in 10.
Okay. And Henrik, this matched in what you do in Gothenburg as well?
That's similar, but most often we do not use the Simoa assay for CSF since we have sort of felt like the analytical sensitivity is not really needed, so we do not occupy the instrument with CSF samples, human CSF samples. But for rodent, of course, one would really like to save the volumes since at least mice do not have that much CSF.
Yeah. And then just for people who haven't worked with the Simoa platform yet, the volume plasma diluted fourfold into the assay is 25 microliters for single analysis. Isn't that correct?
Yes. For the mice CSF, we used 5 microliter volume, pure CSF.
Okay. Maybe related as we're getting into stability, there's a question of stability of archived samples. How far out in terms of months or years have you analyzed samples? I know maybe more anecdotally than being done in a rigorous fashion as of today. Do we have any data if there's a critical inflection point after 5 years, stability frozen at -80, these samples are not useful anymore?
We have no such data in-house, but we have done freeze thawing at least, and there it appears really stable. So it's freeze thawing is not much of an issue for neurofilament light at least. Okay.
And for Jens, I don't know if you had any archived older samples you've analyzed in the meantime.
We've had some very useful data in samples as old as 20 to 30 years regarding serum samples. I do not know what would happen if these were not 20 to 30 years old. And I think it's very important that your comparator groups are at least at the same age, storage time, but there seem to be some reasonable correlations with clinical variables or paraclinical variables in such old samples. Of course, I do not have formal data, except that we also did freeze thawing up to 5 times and room temperature up to 8 days, where we didn't see a relevant effect.
Okay. Then related
I
to
could also add there actually that the boxing data I showed on one of my last slides were on samples collected in 2006, and the nice correlation with CSF was maintained. So it also adds to that this is probably rather stable, I would say.
Okay. So again, just when we finish up on the analytical aspect, so the precision data you presented, the lower limit of quantification was based on a 20% precision cutoff. Isn't that correct?
That's correct.
So typically at the lower end of the curve, towards the LOQ, the lower limit of quantification, what percentage CVs do you see? I think it was 13 or less than 10% on one of the slides, if I remember correctly.
Yeah, I think it's around 10.
Yeah, okay. So for Henrik, for Jens now, is this your same experience now as you've independently validated the assay in Basel?
Yes, this is very much our experience actually, that we do get nice CVs also in the very low range of concentrations. Yeah. Okay.
So then, again, we're coming into the bucket of biological questions here as well to a certain degree. On the first slide, I think, or the second slide after the intro slide, there's obviously various, I call them flavors or forms of neurofilament. There's the heavy chain, which appears to be phosphorylated mostly in fluids. And there's the light chain. There's also the medium chain. So one of the questions shedded or articulated here was, is neurofilament light chain phosphorylated? And I think we know the answer, but maybe we should talk about this and what do we know about comparison to the phosphorylated heavy chain.
I could just mention it's not phosphorylated, and our experience is a bit limited. But when we have done both NFH phosphorylated with our commercial assay, so that and compared with the human diagnostic CSF neurofilament light assay, they correlate. But we haven't done much. We have sort of we have focused on neurofilament light as the marker, and not done much more on the other variants of neurofilaments.
Relatively similar with us, and I think it needs to be really confirmed if heavy chain versus light chain has a different meaning in MS, which it was postulated that heavy chain could represent more chronic damage and light chain more acute damage, but this needs to be followed up.
Okay. So I guess based on some of limited data in the literature, if I may chime in here for a second, it appears that there's, in CSF there are complexes of light and heavy chain. I don't think we've seen data for medium chain. It's a little bit unclear what the stoichiometry of the phosphorylated heavy to the light chain is, at least in CSF. I don't think it has been explored in plasma or serum EDTA plasma for sensitivity reasons. Isn't that what some of the literature suggests?
Yeah, absolutely. I agree. I think that's not really clear at the moment.
Okay.
There's very little medium chain data in CSF around, but nothing in serum or plasma.
Okay. And then another question. So you showed correlation, and you mentioned that this has been done in a number of independent studies between CSF and plasma or serum, and there is correlation between plasma or serum with lower values in plasma EDTA plasma. Where do we think, the NfL, is this brain or peripheral nervous system specific neurofilament light chain we see in the periphery, or is this based on blood-brain barrier disruption as it may occur or does occur in traumatic brain injury, particularly severe, the lymphatic system, or do we think there are other sources for peripheral NfL? Or NfL
I definitely, there is a neurofilament. All neurofilaments are expressed also in almost all in the peripheral nerves. So neurofilament light is expressed also in peripheral nerve. But I still feel a bit reassured when looking at the correlation between CSF and plasma or serum neurofilament light. So I think most of the neurofilament light in plasma is brain derived. But when we talk about traumatic brain injury, and there is in cases where there is trauma also to other parts of the body, then perhaps this could be a confounder that we need to address and really be careful about if there is peripheral nerve injury. But at least to me the correlation indicates that there is a rather clear relationship.
Okay, and then I guess related to this, what do we know about clearance? This question comes up not just for NfL but for other biomarkers in the periphery. Do we have any data in terms of how this is removed from plasma or serum once we find it in plasma or serum, or this is research to be done?
I think there's no data, right? I'm not aware of any data that could be helpful here.
I'm thinking about the traumatic brain injury studies again, where you have one trauma and then you have sequential samples from the individuals. But this is, of course, not complicated because you have also Wallerian degeneration and a continuous release of neurofilament light from injured axons, also distally from the dissection of the dissection point of the axon. So we do not know if the prolonged increase of CSF neurofilament light following acute condition, if that represents a very slow clearance of the protein, or if it's a continuous release. And I think it's the same in the blood. For tau, this is another issue. So to me, it looks like neurofilament light is rather stable in blood, but of course it has to be cleared somehow. For tau, it looks like if you have an acute injury, then you have a rapid increase in plasma tau levels, but also a rapid decrease. So for tau, I actually think there is active degradation of the molecule in the blood. But I have there is not much more evidence than this observation I just mentioned. So I think there is a lot of here we need to do more research, as Jens also said.
Okay. And I guess as you brought up the total tau relationship, let's call it this way, are there in any studies you have done where in blood or in CSF you have looked at the correlation of neurofilament light chain to tau, supposedly both markers of axonal injury, maybe smaller diameter and larger diameters, but what do we know about the release in the correlative release and of a measurement of these biomarkers in neurodegenerative diseases, including on neuroinflammatory like MS?
Exactly. I do not know. We should have some data to examine this, but we haven't done it yet.
Okay.
I mean, in MS, we looked in a relatively limited set of data, and there we didn't see correlations between tau and NfL in MS.
I mean, tau in multiple sclerosis has been, I don't know, disappointing. Is this a wrong word?
Yes.
I shouldn't use it, but it has not lived up to its reputation, I guess. Maybe because of the fact that there's a specific form of tau in CSF. I mean, total tau is kind of a bucket for everything, which may be distinct across neurodegenerative diseases. I mean, tau is also not elevated in FTD compared to controls, unlike Alzheimer's disease, for example. So then, I guess related to this from a clinical perspective, do we know why Henrik showed the slide, controls, MCI and AD, and also across variants of FTD, why we see these elevations of NfL in FTD when compared to other neurodegenerative diseases, and why in AD compared to MCI and cognitively normals? Is there any speculation why we see these elevations in either CSF or blood? I think the data you showed were blood for blood, and then earlier data in CSF.
Yeah, I think there is a lot of neurofilament light in the frontal lobes. And then there is also this, if you also have comorbidity in motor neuron disease and FTD, then definitely you will have. I mean, I think we showed, Jens showed the slide with some ALS patients, because those are also very increased in CSF and serum neurofilament light concentrations because of the release from spinal cord.
Yeah, I agree. I think the spinal cord comes into play here in ALS also, which I'm also puzzled by the FTD. Why exactly in FTD? But that's for me, it's not exactly clear because they don't have a spinal or cerebellar involvement really, right? So,
Well, the FTD with the motor neuron disease phenotype, I mean, they do, because I don't know if they're more ALS than they're FTD, but in some of the behavioral variants, there are high concentrations of NfL in plasma as well in FTD.
Okay.
If I remember the Rower et al., this Henrik's paper as well. So a question with regard to, I guess, clinical management or clinical diagnostic in TBI, so in particular in mild TBI. The data you showed for severe TBI suggested there's more a prognostic management role than there is a diagnostic role. I mean, to diagnose severe TBI, there's really no need for a biomarker, in my view. So do you, both of you, it could be a question, both of you, is NFL ready for management of mild TBI/concussion, maybe 8 in diagnosis in comparison to Glasgow Coma Scale, or to basically, not admit people with mild TBI, but keep those with what we call moderate forms, so CT positive forms of mild traumatic brain injury?
I think that the data speak for that use, but we have to do some more studies, and especially in regards to time of sampling, and so we have to do more studies following mild TBI concussion, and have repeated samples to test following the injury, and also look carefully at the potential confounder from peripheral nerve release. But I think that will be minor issues. If neurofilament light follows the same kinetics as CSF, it might be that it's a bit it might be a bit later as a marker than perhaps it's not a 1 hour sample that will be useful, but perhaps it will still be like, it will instead be like this, that if you participate in a sports activity, you hit the head and you stop playing, and then the day after you do not feel that well, and then you're a bit worried about this, that you perhaps will come to and have your plasma or serum neurofilament light concentration analyzed day 2 or 3 or 4 or something like that, and then you could use it. There was also data indicating that plasma tau works earlier, so perhaps one can have this combined test, plasma tau as an earlier marker and neurofilament light as a bit of a later marker. But this is mostly speculation, of course. We have to do those studies.
Yeah. So, I mean, but you and Kai and co-contributors did publish a paper earlier in the year where you followed and measured NfL over the course of a season in American football players. Isn't that how I recall that paper?
Exactly. Yeah, that's right. And that was there we didn't have concussion data, but we saw a clear difference between. Now I'm not an expert in American football, but between starters and non-starters. And apparently, those who know American football well say that starters have a lot more head impacts, but they also have impacts to other parts of the body. So, but they increased in serum neurofilament light concentrations over the course of the season, whereas non-starters did not. And we are about to complete a study on concussion, real concussion events in American football.
Okay. So in particular in AD, MCI, and cognitively normal, I'm not sure if you mentioned these 5 independent studies. Do we see a correlation between CSF and plasma or serum in Alzheimer's disease and associated disease states, if we call it this way? And are there differences for, let's say, I mean, I don't know if we want to go as far as preclinical AD, but let's say cognitively normal MCI and AD. Is this correlation the same across these different disease states?
I think so, but we do not have the data yet on this, but there will soon be such data.
Okay. So this is work in progress, basically, towards the end of the year. Then the technical question, the capture and detection antibodies, the Oman antibodies now employed in the Simoa assay, are they both recognizing the mid-region of NfL, or are they in the mid and the C-terminal region?
I think both are. I think it's that both are to the mid part, but I do not know the epitopes.
Okay. And then a question with regard, and I'll take this with regard to the analyzer. So the Simoa analyzer, we call this the high-definition 1 analyzer. Jens showed this on one of the slides, is designed as a standalone instrument for clinical chemistry application. So the concept is samples in and results out, basically, and we have a picture there. So it's maybe on the next slide, yeah, there we go. So if we had a person standing in front of this, it's like a cabinet. It's a reader on top of the bench with buffers and others below the bench. That's the side, but this is a standalone unit, basically, where samples are provided, and then 4 hours later the results are available. Another question with regard to the menu now, NfL, with the release of a commercial kit and the availability of sample analysis in the accelerators, there is a strategic focus at Quanterix on the CNS biomarker menu, which includes our total tau assay. There are assays for phosphorylated tau and other synaptic markers being released by Quanterix, a strong focus on neuroinflammatory markers, which have been addressed and compared independently by actually a biotech company. That's a paper which was published earlier in the year across platforms. There are assays which will be made available, commercially available as kits for alpha-synuclein and PTMs of alpha-synuclein as well. So it's a rich menu. There's interest in follow-up. We're obviously more than happy to provide that information.
I mean, maybe I can also mention our strategic orientation in Basel. We are very happy to look into well-defined cohorts focusing on multiple sclerosis or similar diseases. So I'm happy to collaborate and talk to people about these potential collections.
Okay. So maybe a last question. I know Kevin has joined us, so Kevin will close with a few remarks here. Maybe the last question then, if there are no other additional urgent questions, is what do we expect in terms of the correlation between NfL and NfH? So I think this refers to phosphorylated neurofilament heavy chain. in CSF. And as we said before, there's some data which exist in the ALS community and the ALS space, but for other areas they really have to be developed, and they have been limited really by analytical sensitivity of the assay. Isn't that a fair statement?
I agree. I mean, there were some initial hints that in progressive disease this correlation would be less clear, but I really think this is mainly driven by assay performances also, and there's nothing for serum and plasma with this regard. Okay.
And Henrik, I don't know, a final comment or?
No final comment.
Well, good. So let me thank you both before I thank all participants, and don't hang up yet. We have Kevin Rosowski who joined us now, and Kevin will close out this webinar with a few comments. So Kevin, if you've joined us.
Okay, great. I want to thank you, Henrik and Jens and Andreas, for such a productive webinar and exchange. Clearly, the progress is continuing to mount, and you guys have been significant leaders in this field. We, Quanterix, remain very committed to neurology. As most of you know, we won the General Electric NF-L Head Health Challenge twice, and just this week I did speak with the top management of the NFL, and they are very interested to continue our collaboration, which I found very encouraging. We also continue to work with a wide range of thought leaders, as well as pharmaceutical partners who are developing the next generation of neurohealth and protective treatments. We now have placed over 100 instruments around the world and conducted 325 studies in our accelerator services lab. That accelerator has been growing at greater than 100% a quarter. It's just a very rapid growth. A third of our instruments are now in neurology. The balance are in oncology, cardiology, inflammation, immunology, and infectious disease. We were very fortunate to raise $50 million back a few months ago to further develop Quanterix into Simoa Technology, and have announced several strategic partnerships, which we think are critical even based on these discussions today for antibody supply and neuroassays. And that includes GFAP and UCHL1 from Banyan, and 7 new ultra-sensitive neuromarkers from ImmunoArray, Tau, obviously, from ADX, and most recently, we're excited to announce that we just signed a term sheet with Uman Diagnostics for the ultra-sensitive assay to detect NF-L, which directly in blood, which is clearly, the work that Henrik and Jens discussed today. So we're going to continue progressing our investments on every front. We can't tell you how inspired we are by the work that you're all doing in neurology and the importance of it. We also have formed a summit called PPHsummit.com. It's Powering Precision Health. We ran our inaugural session last week, and we'll be running them around the world over the next several years. So if you go onto that website, PPHsummit.com, you'll be able to learn more about the science-driven publications and making sure we lead with the science around all of these different therapeutic areas. So once again, Andreas, Jens, and Henrik, thank you so much for a very productive session today. We really appreciate it.
Well, thank you to Elizabeth as well, and CHI.
Thank you very much. Thank you
to all.